Hello, everybody. Welcome. Welcome to the Research Roundtable. We've got some great opportunity, great guests this evening. I'm very excited about tonight. My name is Eric Ansar. I'm the president of Lympha Press, and I'll be handling the introductions and moderating for this evening. Every month, our Chief Medical Officer, Dr. Karen Herbst, leads a fascinating discussion, and tonight's is no exception. Before we get started, please put in the chat where you're from. Let us know where you're dialing in from. And if you have questions, what we'd ask you to do is go ahead and put those questions into the Q&A rather than to the chat so that Dr. Herbst can address them throughout the program this evening. I'm especially honored to introduce tonight's special guest, someone who has been on our wish list for a long time. And tonight's appearance was booked almost a year in advance because of his busy schedule. Dr. Dhruv Singhal serves as the Associate Professor of Surgery at Harvard Medical School. He's also the attending surgeon for plastic and reconstructive surgery and the director of lymphatic surgery, as well as the lymphatic center at Beth, Israel Deaconess. Dr. Singhal completed all of his formal surgical training in Boston. He's a pioneer in immediate lymphatic reconstruction for the prevention of lymphedema in high-risk patients. And he performs liposuction, venous bypass, and lymph node transplants for the treatment of chronic lymphedema. His research is focused on lymphatic reconstruction, and he's been the recipient of many grants, most recently the National Institute Health Research Program grant, which is one of the most prestigious sought-after grants for independent researchers. And it's just a fraction of Dr. Singhal's esteemed recognition, and I'm very excited about this evening's discussion. And with that, let me go ahead and pass it to you, Dr. Karen Herbst.
Thank you very much. So I am super excited about talking to Dr. Singhal this evening. I dug into him over the weekend and got really excited about some of the work that you're doing. So just to start off, so everybody could get to know you, why don't you tell us kind of what your life is like, what you do in terms of, plastic surgery, research, anything you want to tell us, we'd love to hear.
Great. Thanks, Dr. Herbst. I'd like to begin by thanking Eric, Dr. Herbst, and Lympha Press for this really kind invitation to be part of this webinar tonight. Tell you about myself first. I'm married. I have 3 young boys that are 12, 9, and 6, and they are the light of my life. I am a plastic surgeon. I am dedicated 100% to cancer reconstruction, and I'm 13 years into practice now. In my first 3 years in practice, I did the entire spectrum of reconstructive surgery from head and neck down to lower extremity, again, mainly in a trauma and cancer perspective. I then really became breast and lymphatic reconstructive focused. And I'd say over the last 5-6 years, I've become almost 80% lymphatic and 20% breast. I really take on the breast reconstructive cases now where there is lymph node involvement because a big part of my practice and something I started studying back in 2015 is how can we potentially prevent lymphedema when the highest risk factor occurs, which is an axillary lymph node dissection. So currently that's my practice. I operate 3 days a week. I have 1 day of clinic, and I have 1 day dedicated to research. I have 2 grants from the NIH. We were, I think, on the verge of getting another one, and also talking to ARPA about certain projects that we might be engaging with them on. So I have 1 day dedicated to kind of oversee the entire research portfolio. But everything is really dedicated towards lymphatics, and I'm 48, soon to be 49, and I decided to dedicate my career to this field, as you have, Dr. Herbst, and hope to make some move the needle as you have as well.
Thank you so much. So one of your specialties that we talked about before we started the webinar was the anatomy of the lymphatic system. Yeah. And I don't think most people understand the anatomy of the lymphatic system. We know there's some lymph vessels in us and they pump, there's some posters that are put out by different companies that show lymphatic vessels, but it's a jumble, right? It's for us, it's a jumble. So since your specialty, is kind of breast cancer, I've read some of your papers on the anatomy of the arm. Can you just kind of give us an overview of, like, when you think about anatomy of the arm, like, what do you think about?
Oh, I love that. Thank you for that question. First, it's like just to step back and look at it from a 50,000-foot view. There's a few things I want to talk about. Is why is it 2026 and we're talking about anatomy? Shouldn't the anatomy be all figured out throughout the body?
First.
Yeah, but it's not in the lymphatics. Why is that? Well, it has to do with human nature. Human nature, there's a saying out there, and I often say this in reverse, so I'll try to get this right. The eye only sees what the mind knows, but I'd say the reverse is also true. The mind only knows what the eye sees. And it turns out the lymphatic system's invisible. It's at the gross level, it's 10 times smaller. Lymphatics are 10 times smaller than their counterparts, arteries and veins, at the gross level. And they're invisible because they host clear fluid, unlike blood in arteries and veins, which is tinged red, obviously. Lymph is clear, except around the gut. And for that reason, I think that's a big reason the lymphatic system has kind of been a stepchild in this whole anatomical journey. And to use a word you said about jumble, you're right, it's jumble, it's chaos. When you think about arteries, they have the least amount of variability in the vascular system. Next comes veins, and then next comes lymphatics, with increasing variability as you go down. And that makes sense because whatever variability veins have, lymphatics usually bud from them. So if there's a variability on the vein, it's going to become even more noticeable on lymphatics. So this is why I think when we think about lymphatic anatomy, we often get, we use words like chaos and jumbled, and I think that's where it's coming from. So how do we talk about the lymphatic system of the upper extremity, to get to your question? And this is something that's very passionate to me. It was actually, if you don't mind, I'm gonna share a little story. It was 2017, and we held our first symposium here in Boston, our Boston Lymphatic Symposium, and a Frenchman called, and he said he wanted to give a talk. And all our faculty were already filled, but so he came, I couldn't believe he came anyway, and he gave a 5-minute abstract. And his 5-minute abstract forever changed the course of my research. This was 2017. He got up and showed case after case after case where a woman had an axillary node dissection, and this is Professor Pisas, by the way, from the University of Montpellier in France. And he came and he showed case after case after case where a woman had an axillary node dissection for breast cancer, never got lymphedema. And then she had a skin cancer removal right here. And within a week, she had full-blown lymphedema. And he said, the reason this is happening is it's a double hit hypothesis, meaning the first hit you get is the axillary node dissection, but most women have collateral pathways that can prevent lymphedema from developing. But if you then do something to the collateral pathway, and guess what? One of the collateral pathways is right here. It goes right with the cephalic vein into the deltopectoral groove. Well, now that's the double hit. And that woman is now going to move on to get lymphedema. I'm using the word woman, not man, because most patients with breast cancer are women. And that started me on a journey to understand collateral pathways of the upper extremity. If you don't mind, I'm going to take out my headphones.
Go ahead, take your time.
Can you still hear me well?
Yes, perfect.
Okay, great. So that started me on my journey in terms of understanding collateral pathways. Now, we might have time tonight to discuss some of these collateral pathways, but I want to give you an overview of the lymphatic system of the upper extremity. In 2024, we were funded by Harvard to run a think tank of 16 world experts in lymphatic anatomy and imaging, because we can understand anatomy, but it takes a long time to dissect lymphatic anatomic structures in a cadaver. So a big part of our lab's work is to translate what we know of anatomy from cadaveric dissections to actual imaging. So when a patient walks in the door, we can actually create a map of their lymphatic anatomy. And so in this 2-day think tank, we had some very big key takeaways. And we've published this actually earlier this year in Annals of Surgery. So I'll just share some of these takeaways. When you think about the lymphatic system of the upper extremity, we break it into 2 parts. We break it into the superficial system, and the superficial system is defined as everything above the muscle fascia through to the dermis. And then we have the deep system. And the deep system is everything from the muscle, the fascia, down to the bone. The other key takeaway, and actually, if you think about it, and why is that? I'm sorry. The next thing we're going to say is the superficial system is the dominant drainage system of the upper extremity. So why are we saying that? We're saying that because if you actually look in the superficial system, in cadaveric dissections, there's about 30 channels. If you look below the muscle fascia, there's a few, 2, maybe 3.
Wow.
And the actual diameter of these channels are the same everywhere. So when you just think about it from a capacitance perspective, the superficial system is dominant. So that's the first way we just start thinking about things. Now, we can decide how far we want to go down this rabbit hole, but what happens with injury, such as an axillary node dissection? And this is where we are actually getting closer to mapping how this is happening. We're not there quite yet, but we believe with the superficial, when it's damaged, the superficial system, when it's damaged, tries to find backup pathways, collateral pathways within the superficial system. And if it can't, then it's likely to try to lean on the deep system. And we have actually seen this in functional imaging in women who've never gotten lymphedema, an axillary node dissection, that we actually see rerouting into the deep system at a higher rate than you would see in the normal healthy population. So those are some of the key ways we think about the upper extremity lymphatic system: superficial and deep, superficial being dominant, and then in a setting of pathology, there is a rerouting that occurs. And that's really exciting, that the human body continues to fascinate me. It does reroute. It does try to find ways to heal itself. And we actually think we're better understanding how it's doing that.
So in the leg, there are superficial and deep lymphatics, and one of the superficial compartments is the saphenous vein compartment, either the greater or the smaller. And in that, it's not just a vein in that compartment, but there are lymphatics in that compartment. Is the same thing happening in the arm?
Yeah, Dr. Herbst, you're like leading the witness. Thank you. Yeah, what's happening in the arm is a complete analogy what's happening in the lower extremity. So if you look at the arm, to take your analogy about your discussion about the saphenous vein, when you look at the leg, you have a greater saphenous vein, which runs along the inner part of the leg. And then you have your smaller or lesser saphenous vein, which runs right up the middle of your calf, the posterior calf. Well, it turns out that lesser saphenous vein goes up and goes to the popliteal nodes. And the popliteal nodes are actually a superficial to deep gateway. It is how the superficial system can actually drain to the deep system. And we see that whenever we inject ICG, which is a near-infrared dye we inject in the skin to map the lymphatic system, when we map it around the lateral ankle, we'll often see that chase up right along the lesser saphenous or the small saphenous and go up towards the popliteal nodes. Same analogy in the upper extremity. The analogy to the popliteal nodes are actually the epitrochlear nodes, which sit right on the inside of the elbow.
Mhm.
And with certain injections, we can get pathways that will tend to ride along the ulnar or the medial side of the forearm over to those lymph nodes.
And that's where the compartment is on the medial aspect?
Yeah, I mean, it's many areas of the forearm can go there. So I don't
Okay,
really think about it in terms of compartments. There's a lot of crossover that occurs. I,
okay.
uh,
That's true.
but
Yeah, I saw that.
but yes, we definitely notice that on the ulnar side, which is the small finger side of that hand, and the forearm, you're more likely to get drainage to the epitrochlear nodes. We're actually doing this fascinating series of projects with Dr. Haley Reynolds and her team in New Zealand and her collaborators in Australia, where they have a database of 20,000 patients who had
Wow.
melanomas. And all patients who get melanomas get nuclear lymphoscintigraphy, where they inject the melanoma and see what lymph node it goes to.
Yeah.
They have an XY coordinate system of the arm. And so they know where every melanoma was on every patient
Wow.
in 20,000 patients. So we've been actually working with them, and we've had a series of publications, and there's more that are going to be coming out, because we've been going back and saying, okay, can we create heat maps? And this was Dr. Reynolds is an expert on. She creates heat maps of the arm, and she can tell us where lymph nodes will tend to light up based on the skin drainage. So we know. So when I tell you this portion right here
Mhm.
of the hand and this portion of the forearm tends to drain here, we have strong data to support that.
Mhm. So back to the leg,
Yeah.
so what we see in lipedema often is that around the small saphenous vein, there's a lot of fat. I mean, there's on the back of the calf, there's just a lot of fat. And when you look at the small saphenous vein by ultrasound, it's tiny. So our thought is that there's maybe inflammation of the small saphenous vein, uh, and the fat, grows around it and actually squeegees the fluid down around the lateral malleolus. And so it pools there and grows fat. And you can we ultrasound it and just give it a measure. Um,
Yeah.
but when you said that the small saphenous vein drains into the popliteal nodes, which then go deep, could there be something happening in the lymphatic system deep that's causing fluid to back up and then causing fat to grow around the small saphenous vein?
So just one disclaimer there. I do not treat
Okay.
lipedema patients, but I do,
No, yeah.
well, we do diagnose lipedema in our center through our lymphatic medicine clinic. I will say it's an interesting observation, because in lymphedema patients who
Mm-hmm.
80% in our clinic will present with fat hyperplasia, uh,
Mm-hmm.
and obviously that's a big component of lipedema. That's a defining component of lipedema. I completely agree with your observation. We tend to see the worst fat hyperplasia in the calf,
Yep.
and we tend to see the highest volume in the posterior calf. So
Yes.
completely agreed. Now, so I guess the question you're asking is, or based on your observations, you're wondering, is it possible that there's a deep lymphatic drainage issue that is causing fat development in the posterior calf? Is that right?
Correct. That's right.
Yeah, it would be hard for me to answer that. The only thing that I would say to that, and again, I don't treat lipedema, but we do help with the diagnosis of it in our
Mm-hmm.
center. And I do know when we get nuclear lymphoscintigraphies, they tend to be normal,
Pretty
meaning,
normal. Yeah.
yeah. So that would speak against that, though, if I want to debate myself here, which is we do inject in the superficial system when we
Yeah.
do it. But based on our experience, again, with normal healthy volunteers, even when we inject the superficial system, we know there's superficial to deep connections, even in a healthy population.
Right.
So you would expect that if there was major deep dysfunction, that we would have caught it on some of these lymphedema patients, and I
Okay.
can't say that we have.
Okay, that's good. I mean, it's good to kind of put those things aside. And so it could be just due to inflammation. So back to the arm.
Yeah, I love it.
So you talk about axillary node dissection, and that can pose a problem for a woman and put her at risk for developing lymphedema. Is it, I mean, there's a lot of lymph nodes in the axillary area, right? What is it? How many do you have to remove to cause a problem? Or would it be like the inside versus the outside? Is there any, place where you can remove axillary lymph nodes and not worry about it?
Yeah, it's like, again, great questions. So as you noted, a lot of variability in number of lymph nodes in the axilla. Axilla means armpit, um, for some members of the audience. So in the armpit, we did a study when I was at the University of Florida, or just looking at our own patients, and on an axillary node dissection, sometimes 10 lymph nodes were removed, sometimes 40 plus lymph nodes were removed. So a lot of it is based on the technique of the breast surgeon. A lot of it but when a breast surgeon does do a formal axillary lymph node dissection, the traditional answer is to remove what we call level 1 and level 2 lymph nodes. And this is defined by the lymph node orientation to the pectoralis major muscle, pec minor muscle, to determine which lymph nodes are removed. The literature will tend to support if 4 or more lymph nodes are removed, your risk of getting lymphedema starts to rise pretty exponentially from there. The most common lymph node evaluation done by breast surgeons in this country is a sentinel lymph node biopsy. This is where they identify 1 to 3 lymph nodes. That's the traditional kind of thinking of this, where they go in and they take out those 1 to 3 lymph nodes to make sure the cancer from the breast has not kind of spread.
Mhm.
Now, if it has spread, then they're going to discuss potentially removing more lymph nodes. One of the things we're seeing in breast surgery is a tend towards removing less lymph nodes because of the desire to reduce the rate of lymphedema. So there are a lot of studies where they are downstaging the axilla, meaning 30 years ago, certain findings on those sentinel nodes would have guaranteed a woman a completion axillary node dissection. But
Mhm.
today, breast surgeons are definitely being more critical about whether or not they need to do that, or if they can just chase their treatment with radiation therapy.
I'm going to look at the questions real quick.
Yeah, great.
So one of the questions is, can knee replacement surgery cause lymphedema of the lower leg?
That's a good question. I think any extremity surgery could cause lymphedema of the lower extremity. I will say though, I don't know of any patients in my practice. We've seen over 4,000 patients at this point in our center for lymphedema, and I'm trying to remember. The fact that I'm thinking this hard makes me say that the risk is probably on the very low side after a knee replacement. But I see somebody in the chat saying yes, it happened to them after a knee replacement.
Mm-hmm. But to me, that sounds like the second hit, right, that you mentioned. So you've got maybe a underlying primary, or you've got some lymphatic dysfunction, and then you get a surgery on top of that. That could be a second hit.
Or you have different lymphatic anatomy. And
Or that too.
so because if the standard incision done for a knee replacement caused lymphedema, then everyone would get lymphedema, or the majority would. And,
Right, right.
knee replacements wouldn't be done, or something would have changed. If it is happening, then it's likely happening because of some aberrancy.
There's a similar question, and it's from somebody who said that they've had primary lymphedema for 12 years, then they had an abdominal bleed. And so they had just IVs all over the place, PICC lines. And after that, they developed full-blown lymphedema in their arms and they're struggling with fibrotic tissue. It sounds like that's like a second hit again. And their question is, do you suspect the arm swelling was due to all of the pricks and pokes?
Yeah, and this is a controversial topic. I want to start by recognizing that. And there are people who say there is not data to say what I'm saying, and I would agree with that. But based on my study of lymphatic anatomy, I do believe blood draws carry a risk for causing lymphedema. And let me explain where I'm coming from, because
Okay.
I'm saying something that I want to recognize some of my colleagues will disagree with because the data is not strong or even present on this. But this is, it goes back to the double hit hypothesis. So let's say a woman's had an axillary node dissection. Now, some of her collateral pathways are what that woman is relying on not to get lymphedema. But guess what? Let's talk about the SAPI pathway, the lateral upper arm pathway. I'm giving it a few different names because
Sure.
it's called a lot of things, and we tend to use a lateral upper arm pathway. Anatomists 200 years ago defined that pathway given its proximity, its closeness to the cephalic vein. So think about that. If you have a phlebotomist that now is going after the cephalic vein and misses,
Right.
and they hit and go
Right.
through the SAPI pathway, which now this woman might be relying on, you can
Right.
see how that can then send them off into lymphedema. So again, I want to recognize that this is a theory. This is a theory based on our research, based on what I know of lymphatic anatomy, but we don't have good data to support this. This is a very challenging thing to study.
I find that to be very interesting. I'm not a big, I can do surgery on somebody else, but I do not like getting my blood drawn because when they pull on the needle, I can feel it, throughout my tissue, throughout my arm. And it's not a minor thing. It's a major, they're busting through a vessel. That's a big deal. And thank God for blood tests. I mean, we rely on those and I order them all the time, but at the same time, I think it's wise what you said, because I think anytime we poke somebody with something, we should really think, do we need this?
Completely agree with you, Dr. Herbst. And in my practice, because the majority of patients I treat are at high risk for lymphedema or have lymphedema, everyone in the OR, including the anesthesiologists I work with, know we want no draws, no IVs in the at-risk extremity. That said, like you said, everything's a balance. I remember one day where we couldn't get an IV anywhere else. And the anesthesiologist was opening up a central line kit. And this is where we actually try to puncture a deep vein to get blood access. And that's where I said, okay, there's no right or wrong answer here. But I always think if it was my family member on the table, I'd rather you not do that. And let's go ahead, let's get an ultrasound, let's do the best we can if we have a vein that we think we can reasonably get in the at-risk arm. Because I don't think it's the act of getting the blood that causes an injury. I think if you miss the vessel and you hit lymphatic, or you get a hematoma, which means you puncture the vessel, you come out, and then the blood goes into the soft tissues, causes inflammation of that adjacent lymphatic channel. That's where I think problems come. So yeah, just wanted to clarify that. So it has to be really thought out.
Yep. And that's one of the reasons why we say, not to draw blood out of a specific arm, especially if there's a higher risk of lymphedema for that arm or lymphedema is already present.
Yeah, for my family member, that I would try to avoid it. But again, I want to recognize that the data is lacking on this.
Yeah, so there's a big, that just opened up. Everyone's like, oh, I have something. So somebody said they know a young woman who had normal lymphatic flow prior to her last childbirth and hysterectomy. She then developed secondary lymphedema, and it was apparent that the surgeon inadvertently damaged the groin lymphatic vessels. I wonder how often that's happened, because I remember early in my career, I had women coming in saying I had a hysterectomy and now I look like this, and they had lymphedema.
Yeah,
So,
I'll be honest, I haven't seen that so much in our practice, but we have absolutely seen certain transplants where the transplants put into the groin area with subsequent lymphedema development, likely because of damage to the main lymphatic coming through that space. Again, no surgeon ever is trying to harm their patient.
oh,
These are just invisible structures. And, and this is a very well quoted fact that there's only fact or statistic that there's only 15 minutes spent in all of med school on the lymphatic system. And I think a lot of us, including you, Dr. Herbst, is a champion on the system, are trying to change that conversation and have med schools talk about the lymphatic system, talk about lymphatic anatomy as part of their anatomic dissections. And that's what we hope, for example, our work will motivate anatomy labs to consider, hey, should we be teaching or have a module on the lymphatic vasculature?
yeah, absolutely. So what about radiation? What's the risk of radiation causing lymphedema?
That's a great question. So if you look at the literature, and we're going to stick to the upper extremity here. So if you look at the literature, the risk of getting lymphedema after a sentinel node biopsy, which is just 1 to 3 lymph nodes, is about 0 to 5%. I will tell you, based on our clinical practice, I think it's towards the lower end of
Okay.
that range. If you look at somebody who gets an axillary lymph node dissection alone, no radiation, your risk is running around 14%. If you look at somebody who gets a sentinel node biopsy and radiation, and when I say radiation, I want to be clear, there's different kinds of radiation. There's radiation you can get to your chest, and there's something called regional lymph node radiation. Radiation delivered specifically to this area. With regional lymph node radiation, you're looking at a risk of about 11%. That's just with 1 to 3 lymph nodes removed. If you get both an axillary node dissection and then that regional lymph node radiation, they basically become synergistic, unfortunately. And your risk becomes around 26 to 33%. 93% of women in my practice who get a true axillary lymph node dissection, level 1, level 2, go on to receive regional lymph node radiation because it's evidence that the disease is a little more advanced. And therefore, then the cancer team is going to make sure they treat that area adequately. So, in the majority of my practice, I quote women the risk of lymphedema at 26 to 33% because I expect them to get both treatments.
Right. Wow. That's high.
Yeah.
And so after surgery and after radiation, how often are you monitoring these women for lymphedema, and like what do you do are they all wearing compression garments, or I'm curious.
So we have a very robust surveillance program. Any patient that's first identified as high risk, meaning they may be going on to a full axillary node dissection, they're referred to our center. We actually do a mapping of their lymphatic anatomy. So we inject ICG and we create a map, and it's documented in their chart. And this is really important because it might be the last time we're going to have a map like that. Because once you go in and you disrupt those lymph nodes, you might lose that map and not be able to say where things were. It's the first thing we do. The second thing we do is they're evaluated by a certified lymphedema therapist. They're educated about the warning signs of lymphedema. We get volume measurements between the two arms, and we also do bioimpedance. So we actually look at extracellular fluid as a comparison between the two arms. The patient then goes on to surgery where those lymph nodes are removed, and we do perform a procedure to reduce the risk of getting lymphedema. And then that patient is followed up 4 to 6 weeks after surgery, 3 months after surgery, and then every 3 months for 2 years. If they clear all of those numbers, and whenever they come back, we don't re-inject them for a map, but we do get their volume and we do get their bioimpedance. These are non-invasive. They come in, we're not We're not poking them or anything. They're stepping
pretty
on scales and whatnot. If after 2 years they've cleared all those values, we will then go on to another 2 years where they come and see us every 6 months. At that point, we really leave it to the patient to make a decision on how they want to move forward. We don't want our patients walking on eggshells. We know statistically the majority of patients are going to present in the first 4 years. So after that, if a patient's saying, look, I still want to be seen, we'll see them every year if they want, come in, get measures, check on them. But if they don't, we let them know we're here for them and they can come back anytime. So that's our surveillance program as we do it.
Okay, these are there's some personal questions on here. People are very interested in, their history, and I absolutely don't blame them at all for that. So, somebody says I contracted lymphedema after an operation for a benign cancer on my kidney. Am I condemned to a daily session or 2 of the Lympha press, or is there hope?
Yeah, it's really hard to answer that question. I think there's always hope. Let me begin with that. I'm going to actually start with that. I mean, we are. I have there's a world expert lymphatic surgeon and imager, Dr. Aki Hayashi, here in Boston for 2 days. I just spent the day in the OR operating, and he came into the OR, and we're all learning from each other and sharing ideas. And I asked him this evening, I said, Aki, think about where we were 10 years ago and where we are today. And it's night and day. We are starting to find commonalities in our practices. And I'm talking as a surgeon, but I probably would say the same thing's happening with certified lymphedema therapists, with lymphatic medicine doctors. And, we are starting to find pathways where we can find somewhat reproducible results. Listen, we're not there at a cure yet, reproducibly, but we're all working towards it. Look at ARPA. ARPA is the Advanced Research Projects Agency. They've put out over $100 million over the last few years dedicated just towards lymphatic research. There is so much happening. So anybody living with lymphatic disease, dysfunction, yes, I think hope should be the first word in your vocabulary. That said, it's hard to comment on that specific case without knowing more about the situation and whatnot, but there is a message of hope here.
So I would like to just get your take on medications being developed for lymphedema. What are your thoughts on that? Is that an exciting area, or is something really going to happen there?
I think there's no question something's going to happen there. If you look at the incredible work Dr. Roxon's doing and other teams here in Boston are doing, I think there's tremendous hope. If you ask me, and patients sit in front of me as they're talking to me about surgery, and they say, Dhruv, is there going to be a medicine that's going to cure me in the next few years? Like, should I really sign up for surgery with you if there's something right around the corner? And I think Dr. Roxon has actually said this, and I agree with him. I think the future holds where these therapies are going to work conjointly. They're going to work together towards treatment. I don't know if there's going to be a silver bullet surgery. I don't know if there's going to be a silver bullet drug, but I will tell you there are major advances occurring in all of these avenues, including lymphatic therapy with ICG-guided MLD and whatnot. So I think there's so much happening, but I don't know. And there might be a researcher out there on the verge of a drug that's going to cure lymphedema. And I've told all my patients, the day that's out there, I will call all of them, give them the drug, and close my practice. And I'll be happy to do that because that's our job. Our job is to put ourselves out of business. But I think the future are going to be these drugs that are going to work in concert with other conservative and potentially surgical therapies.
So you mentioned the ICG directed MLD. How come Europe has that and we don't here in general? What's up with that?
Yeah, I can't answer why that is, but I'll tell you what we did about it. So
Okay.
our sister program's the ALERT program. The ALERT program is at Macquarie University in Australia.
Okay.
And we meet with them every 3 months. We have a Zoom like this, probably have 40 people on the call, 20 from our team, 20 from their team, and we share ideas. And Dr. Louise Kohlmeyer, a physical therapist, she shared this program with us years ago when we started these meetings. So I sent one of our therapists, my nurse practitioner. I sent a research fellow out to go learn that program and bring it back. And that's what we've done. And I'll be honest, Elizabeth Tillotson, she goes by Tilly. She's my nurse practitioner. She leads that program. We set up clinic visits where Tilly will inject the ICG. A certified lymphedema therapist will be right next to her, and we'll create maps to see where is the dye going. We'll create a map, send the patient home with a map so their local therapist can see where they might get better drainage. We specifically do this. We can do this anywhere, but we specifically do it for the breast. And let's be honest, it's hit or miss. Some patients swear by it. They say this has been life-changing, and others say it hasn't helped that much, which tells me we're missing something.
Yeah.
And I actually think what we're missing, this is a little tangential to your question, but what I think we're missing is the deep system. We
Yep.
don't have any good imaging technique for the deep system.
Yep.
And I think we can only tell so much on the superficial system. It's like a glacier. You
Yeah.
see the tip of it, but you don't know what's happening
Right.
underneath. Yeah.
I agree. Yeah, I feel like that's like the door's closed for me. I want to open it, but I can't. So I can only look at, I use ultrasound. I look at fat tissue and vessels, and I can just make guesses. But I feel like I'm still throwing darts, and I don't like to throw darts. I like to know what I'm treating.
The ARPA program, the LIGHT program, is
Mhm.
specifically looking at lymphatic imaging. And so hopefully there will be things that come out of that program that will, no pun intended, shed light on this. But, it's very interesting because if you want to see the arterial system, if you think about it, all you have to do is put a drop of dye into an artery and let
Right.
the pump of the heart take it everywhere. So
Right.
you have that advantage. And then if you want to see the venous system, you just have to time your imaging so it clears the artery and now it's in the vein. But
Yep.
you can't do that with a lymphatic system. Where are you
Mhm.
going to inject? You can inject here, but then your imaging is only going to tell you what's draining here. It's not
Right.
telling you about the entire hand or the entire
Right.
forearm and the entire arm. So that's the big challenge that honestly awaits us in terms of trying to figure out a comprehensive way to see the lymphatic system.
Mhm. Back to anatomy.
Yes.
Yeah, so Marilyn Lee says, can you share where lymphedema in the breast drains? This can be a difficult area as there is no muscle pump to assist with drainage.
Yeah, so this is a great question. And this is something Dr. Kohlmeyer has taught me a bit about. So breast lymphedema is actually more painful or uncomfortable for patients than arm lymphedema. And she explained to me why, and it makes perfect sense. It's because of the astute question that was just asked. The distance from the skin to the muscle is actually very small in the arm, right? So the distance from the skin to the muscle fascia is actually very
Yeah,
short.
very, very short.
So when a patient's moving their arm, they're naturally pumping their lymphatics. In the breast, unfortunately, not so much. The distance
Right.
from the skin to the pectoralis major muscle is quite long, and depending on the size of the breast, it can be even longer. And so that actually makes breast lymphedema a more uncomfortable condition across the board, bell curves here, than arm lymphedema. Now, where does breast lymph drain? I think the question was, where does lymph in the breast drain?
Yes.
So we know that patients are at higher risk of getting lymphedema after lumpectomies. That means partial cancer excisions in the upper breast, upper outer breast, and also kind of the lateral breast.
Mm-hmm.
So that speaks to the fact that the breast's primary drainage is to the armpit, actually. That said, there can be drainage that goes to lymph nodes along the sternum. It can also have drainage that goes across to the other side,
Wow.
but it tends to be to the armpit on the same side.
Okay. So if you have a patient with breast lymphedema prior to radiation, is there something about the radiation that could cause additional scarring for that person who already has lymphedema?
Yeah, that's not a clinical scenario I believe I can recall, but yes, radiation will tend to cause scarring. It's like a controlled burn, and so um, you know, and if a patient, usually breast lymphedema occurs after radiation. The
Right.
normal scenario is a patient gets a lumpectomy.
Mm-hmm.
And the standard of treatment after a lumpectomy in most cases is radiation to the chest, and
Mm-hmm.
then the lymphedema comes on.
Mm-hmm.
But unfortunately, I think if somebody has lymphedema before breast lymphedema, before radiation, um, I think there is a potential for exacerbating the lymphedema.
Yeah, that makes sense. So what about bras? Is an underwire bra something that prevents good drainage, or can you wear any kind of bra for good lymphatic flow in the chest and breast?
Yeah, so I'm not a lymphatic therapist. For my lymphatic therapy team would be all over this question, but there we I do not believe there's any concern about an underwire in terms of causing breast lymphedema. We actually, interestingly though, I will tell you, we just came back from a visit to Professor Ciucci. Professor Ciucci is he's at the University of Buenos Aires in Argentina. He was the disciple of Dr. Kaplan. For those who are familiar, there's a pathway in the posterior upper arm called Kaplan's pathway. It's also believed to be a collateral pathway. And our team made a trip to study with Dr. Ciucci to learn more about that pathway. And I bring that up because Dr. Ciucci believes a bra strap a very narrow bra strap can occlude critical lymphatics around the shoulder girdle. So he actually showed us that he creates an insert. You can buy an insert to go under the strap to distribute the pressure in this area. So just talking about bras potentially occluding lymphatic flow, that's one thing I would bring up. And I would also just bring up that there are specialized bras that have been created that are very good to assist with breast drainage. Though I wouldn't feel comfortable commenting on
Yeah.
those different things.
That's one of my big things is when a woman comes in and I see this bra like digging in, and then under it is a bulge in the tissue. And
Yeah.
yeah, and anytime you have a bulge in the tissue due to pressure right next to it, you know that vessels of all kinds are dilated in that tissue. And then so there's leakage and there has to be more lymph drainage. And if your lymphatic system is suffering already, it's just a setup for fat growth and fibrosis. So I do like the bras that have wide bands at the bottom that distribute the pressure. So I totally agree with that. I don't like straps digging in up here. So I like adjustable straps at the shoulder. And then you're right, there are other aspects of the bras that can be, different and help with drainage. Like Karen Ashforth is a well-known physical therapist, and she created the Karina bra, we call it, but it's actually Karen A bra. And it's got kind of the micro massage on the inside of the bra to help drain any kind of fluid in the breasts or anywhere on there. So there's lots of options, but do not ever let anything, underwear, I don't like digging in, bras digging in, Watches digging in. I mean, everything that digs in, I'm looking at and saying, no, no, no. Most women are really good about it. Most women were very comfortable underwear. The bras are always a stickler for me. Okay, bunch more questions. Is there any evidence that breast lymph can drain to the ipsilateral groin?
Yeah, I want to say yes to that. Though, we have seen drainage go downwards from the breast to the ipsilateral groin. We have seen that. Yes.
Okay. And we talked about blood draws, but somebody's asking about blood pressure. Do you take blood pressure in the arm that may be affected by lymphedema? And she says, as a nurse, I obviously avoid the affected limb, but how concerning is taking blood pressure?
Yeah, I would say the same caution. With blood draws, I can see the clear path in my head with anatomy. With a blood pressure cuff, less so. But again, for my family member, if I have another very good arm, I would just use the other arm.
Yeah, I just got corrected. Karen Ashforth and Dr. Kohlmeyer are occupational therapists, but they are certified lymphedema therapists. I know Karen is. I don't know Dr. Kohlmeyer personally. Thank you for the correction. So what would be how would you, like, if you have to get your blood drawn, what are some safeguards? This is from another question. What are some safeguards when your blood is drawn? Because everyone's susceptible to possible lymphedema with the blood draw if you are at risk. So each blood draw is a second hit, right? So what are some safeguards?
Well, I don't think each blood draw is a second hit. I think if that blood draw somehow goes into a lymphatic, then it could be a second hit, in my opinion, based on what we know
Right.
about lymphatic anatomy. So I think the biggest safeguard is to try to avoid it. And I've seen women when they come into the hospital, they'll put a little sleeve on their arm. I don't mean like a compression sleeve, like that, like something loose that just says no on that side. So everyone knows from the moment they walk in, nothing should be done to that arm if at all possible.
That's a great idea.
Yeah.
Even like a medical bracelet that you wear might be helpful too.
Right.
Especially as we age and we forget to say anything about things. So, so we're getting down to the end of the hour. Is there anything that we haven't talked about that is exciting for you, or are you thinking about the future? And is there something that's coming down the pipeline that you could barely contain yourself about?
I really, it comes back to what we've talked about. I think lymphatic care is entering a new era. It's going to be an era of precision medicine. It's where it's not just, an axillary node dissection gives you X amount of risk and regional lymph node radiation gives you X risk. It's going to be, you, Dr. Herbst, have X risk based on your anatomy. And this is what we're going to do to make sure you never get lymphedema. God forbid you need anything. Or me, I walk in, I have a medical problem, and somebody's going to know to check my lymphatic system, understand my lymphatic system. And prevention is the future of this field, in my opinion. And I think our research on prevention will inform how to treat patients as well. And even when you think about pneumatic pumps, Eric and I were involved a little bit in a project about looking at pneumatic pumps. Could it be part of an era of precision medicine where maybe pneumatic pumps can feed back information to clinicians, and maybe the actual pumps could be tailored to the actual physiology of a patient. We're working with the Biomedical Engineering Institute over in Auckland, and we're looking at wearables, a device that a patient potentially wears that's high risk. That could be an early warning system. Pneumatic pumps have a huge advantage that you wear them, right? So that they're connected to a machine. So you could potentially extract data from that. I know that's stuff Eric, Lympha Press, we've ventured into in the past. So I think that's what excites me, is that getting into an era where we get more precise in how, across the board, whether you're a therapist, surgeon, medical doctor, how we approach patients with lymphatic dysfunction.
I think that is exciting. One thing we didn't talk about was electricity. Because we are electrical beings, and electricity causes you can get your calf muscle to pump. And I wanted to know your opinion on the little fireflies. Have you seen the fireflies that you strap around your calf, and they basically cause your calf muscle to pump, and you can wear them on an airplane to decrease your risk of swelling? They're throwaway.
I don't think I can give an opinion on that. I don't know very much about it, but
Mhm.
I'm just going to talk logic based on
Yes.
what I know. Anything that causes a muscle to fire is likely going to assist the overlying lymphatics to pump. So I think
Mhm.
there's a role to that, but I also don't
Mhm.
know how it affects muscle fatigue and other things. So I don't really want to make
Right.
an opinion on that. But anything that makes a muscle pump, we know exercise is huge in patients with lymphatic dysfunction.
Yes.
High reps, low weights, we see remarkable outcomes. So I do think there's probably something to that.
And we had talked about exercise on the program, and we think weightlifting is really important. Like you said, high reps, low weights. You don't have to be, lift 300 pounds. You just lift a small weight multiple times, taking care of your joints, especially if you've got hypermobility.
Yeah.
Our moderator is back.
Yes, I'm
great.
back. This has been a fantastic conversation. Thank you so much. I was listening to you talk about the amount of education on lymphedema inside of medical schools, and I just applaud the two of you for what you do to educate the community. It was a wonderful conversation. I know, Drew, you took a minute to kind of share some final thoughts but before we transition, is there anything you wanted to leave with the audience? Any final thoughts before we go?
I don't want to repeat myself, but I think what I want to emphasize is the message of hope, that there is so much being done, and if based on where I sit and what I saw 10 years ago, what I see today, I think there's so much more technology that's being available to us, so many more medical policies being passed supporting the care of patients with lymphatic disease and dysfunction, that it's not just that the needle that the pendulum we're going in the right direction. It's occurring at a breakneck speed as well.
Yeah.
And
Mhm.
and I know, Dr. Herbst, you see that, and Eric, you see it. We're all at the same meetings, so we see
Right.
what's happening. And I think I think if there's one last thing I want to share, I think that's
That's
what
a
I want to leave with.
That's a beautiful message. I will share that about 2 years ago at Lympha Press, we actually changed our core value statement to be hope, just an acronym of hope, because for the exact reason you're talking about, we just have recognized it actually came from a mutual friend who a lot of us know. She was a patient, and she was talking at a panel discussion, and she was talking about, as a young girl, she started a blog because she had primary lymphedema, and she felt like she was reaching out kind of into a void. There was just nobody there. There was nobody sharing anything, and she was just sending this message out. And as we sat there and listened to her, we realized our industry, people like the two of you, what we try to do at Lympha Press with these roundtables and things like that, is really designed to deliver hope to people who might feel hopeless. And I would agree. I think the opportunity is changing. We're kind of entering the golden age of lymphedema, and I think there's going to be a lot of continued change, and it's a very exciting time to be in this industry for us and for the patients we serve.
Couldn't agree more, Eric. And I have to tell you, one of the other great parts of this field is people like the two of you. That we were all in it for the patients.
Yeah.
We don't really care what the truth is. We just want the truth.
Right.
And, and I really mean this. Like
I love that.
I said, if I figure out how to cure this disease, or somebody figures out how to cure this disease, I might retire. Like, we just want this figured out. And it's a field of humble people like the two of you that we're just here to try to figure this out.
It's wonderful. Karen, can I pass it to you for any final thoughts for our
Yeah.
audience before we let everybody go?
One of the things I say is I love to be wrong because then I learn something new. And I also want to thank you, Dr. Singhal, for going back to the basics and studying the anatomy of the lymphatic system, because we need that so desperately. And you're doing it, and you're doing it with so many other people. And I agree, the future is going to be exciting, and I'm going to retire and just watch it.
I love
Dr.
it.
Herbst, thank you. Thank you for your kind
Thank
words.
you
and
both.
your
Thank you.
humbleness.
Yeah. Appreciate
Thank
it.
you both so much.
Have a
Thank
great
you, everybody,
night.
for being here this evening. Have a nice evening.